course, that while the Commonwealth represents about 30% of the world's population, we have about 40% of the global cancer burden as far as cervical cancer is concerned. And I think what should be more concerning to everyone in this room is that we're also carrying 43% of the overall mortality. Now, how do we shift narratives around this? What we do know is that not only are our women diagnosed late, they frequently do not complete their treatment. What are the reasons behind this? We have a constellation of factors that we've really been talking about throughout the course of this forum. One, the fact, we look at the constellation of factors. One, the fact that ladies have to pay out of pocket. We've talked about economic empowerment and financial stability. Quite a number of our patients have to pay out of pocket, resulting in financial toxicity and catastrophic health expenditure. We do know that even when patients are diagnosed and engage with the health system, for instance, in sub-Saharan Africa and in certain parts of the world, it will take on average 3 to 6 healthcare professionals, consults or interactions with 3 to 6 healthcare providers before a definitive diagnosis of their cancer is made, really calling for a reason to strengthen our health systems. And then, even when the diagnosis is made, we often forget the social-cultural barriers that exist. And these are the matters that we've been discussing. In certain parts of the world, as we've heard in the conversations earlier today, women are not the primary determinants of their health-seeking behavior, and as such require either permission or financial support in order for them to access care. So how do we shift narratives for our women in the Commonwealth? And that is the whole point behind this conversation. So this session is meant to be really interactive. I'm hoping that as we sit there and think about what are the opportunities that we can all bring to the table in terms of helping to shift narratives for our patients. So first up, to make some opening remarks, I'm going to invite Professor Ruth Katamuri, who is the Senior Director of Economic, Youth and Sustainable Development at the Directorate at the Commonwealth Secretariat. She's responsible for the Commonwealth's Secretariat programs pertaining to sustainable and inclusive development involving advocacy, technical assistance, knowledge sharing, and capacity building. Welcome, Prof. Katamuri. We're really excited to have you on. Thank you.
Thank you very much. Distinguished participants and Commonwealth friends. And I want to thank all the teams who've been working extremely hard, my gender team working on the entire forum, along with the government of Rwanda. So I would like to thank the government of Rwanda and all the distinguished guests who are here, First Ladies of Bahamas. Thank you for joining us for this very important session, and your team. So we're delighted that you're all here with us today for this very important session, as our moderator also said that, and the MC before that said how it has been part of her experience. Any session after lunch is always very difficult to focus, and more so the last session or the penultimate session after 2 days of engaging conversations. So we, as has been mentioned before, are trying to make this session lively. So what I want to do is I want to start by referring to the exercise called pyramids. I don't know how many of you have done this exercise called pyramid. It's become a common sport now. It was one of my favorite sports in school, and I'm sure some of you here today would have also done it. I'm not going to ask for a show of hands, but you will know the answer yourselves. So why am I referring to pyramids? This is to highlight, firstly, that the work we are doing now, we build on the shoulders of all those who have worked extremely hard before us, and to thank all their efforts. Secondly, we have to do one more thing. We have to enable our children with our common wealth. You've heard this phrase earlier in this forum. We have to enable our children with our common wealth to progress faster to achieve our, what do you think it's going to be, common goals. I just want to start with that phrase. And in that context, I would like to introduce to you the youngest member of this forum that I met last night. Her name is Halima Oikemi. She's from Nigeria. I'm just going to call her forward. She had a script to read. I want to make her stand there. I don't know if there's a roving mic I can get. Is there a roving mic? You can't see her, so I want to make her stand on the step. Halima, come here. Come to the stage. Can you just say who you are and what you've been doing?
Okay. Hello everyone here today. My name is Halima Onyekehe. I am a child speaker and a child advocate. I speak for the African children across the world who are getting molested and abused. So I speak for them. Thank you very much.
So why did I want to introduce Halima in this session? Because what she's doing is for the welfare of health and well-being of our children. This session refers to that. She has already written a book, and her inspiration was because when she went with her father in and out every day to school, she would see poor African children in poverty, in sorrow and distress. And she's already written a book, ladies and gentlemen. So let us give her another big hand. The disproportionate prevalence or incidence of cervical cancer in the Commonwealth. Of 1/3 of the world population, 40% has incidence of global cancer and 43% has cervical cancer. And some of you might be wondering, why are we focusing on cervical cancer alone when there are so many other cancers related to women's health, such as breast cancer, uterine cancer, and ovarian cancers? The fact is, among all these 4 cancers, cervical cancer is the only one that has proven efficient, effective elimination strategies. Through the human papillomavirus vaccination, HPV for short, and early screening tools for precancerous lesions. So, there is no valid reason for cervical cancer not to be eliminated. And that is why this discussion today is very important. However, even though we have the tools and mechanisms, evidence suggests that incidence and mortality rates due to cervical cancer are still high among many low and middle income Commonwealth countries. Unfortunately, progress has been slow because many low and middle income countries experience challenges with access to screening tools and HPV vaccines. In addition, stigma and misconception surrounding cervical cancer is high. Hence, there is an urgent need to work together for elimination of cervical cancer. And it requires bold strategic policies and actions by governments, health professionals, and community organizations involving women and youth in health advocacy to improve awareness and address access challenges. So what is the Commonwealth doing? The Commonwealth heads of state and health ministers have continued to give prominence to tackling cervical cancer, leading to several key policy recommendations. At the recent Commonwealth Health Ministers meeting in May 2022, the health ministers renewed their commitments to advance efforts in accelerating cervical cancer elimination, improving policies and legislation to non-communicable diseases elimination, and addressing inequity in access to cancer medicines and vaccines. Secondly, the Commonwealth Secretariat launched an international task force for cervical cancer elimination. This task force was launched in 2021, and our speakers today are represent this task force. They will be supporting, this is with the purpose of supporting the efforts of our member countries in this regard. We have also developed a Commonwealth information and price sharing database towards addressing the challenges of inequitable access to vaccines and other health commodities, including essential cancer medicines. Thirdly, we are working in collaboration with the WHO Union for International Cancer Control for the implementation of WHO's global strategy. We continue to work closely through the MOU we signed in February 2022 with WHO in our joint cervical cancer elimination efforts. And Dr. Princess Nothemba Simelela is on the panel of speakers with us today. We have also just published a Commonwealth advocacy tool titled Addressing Myths and Misconceptions. You can probably not read what's there, but it's talking about myths and misconceptions around cervical cancer. This is available online, and there are a few printed copies if anybody would like one. And we have my health advisor, Janet, who's in the yellow jacket, so not difficult, not hard to miss, who will have some copies if you wish to get it, and also if you need any more clarification. Today to ensure solution-oriented commitments toward elimination of cervical cancer by 2030, if not before. With that, I hand you back to the moderator.
Thank you so much, Professor Katamuri, for really setting the stage and giving us a sense of what the Commonwealth is doing to actively try and combat the challenges that we're facing. And as we said, one of the key tenets is around collaboration and connectivity. And Prof. Katamuri talked about the International Task Force for Global Cervical Cancer Elimination, and one of the key partners of that is the WHO and the Union for International Cancer Control. And so it gives me great pleasure to introduce our next, our keynote speaker, who will be talking about the elimination of cervical cancer in the Commonwealth. None other than Dr. Princess Nono Simelela, who is from South Africa and is the Assistant Director General for Family, Women, Children and Adolescents at the World Health Organization. Dr. Simelela has more than 30 years of experience as an obstetrician, academic, advocate, and government official. Most recently, she served as a special advisor to the Vice President of the Republic of South Africa, where her work spanned supporting the implementation of the country's national strategic plan for HIV, TB, and sexually transmitted diseases to reviewing the country's expanded public works program. Dr. Princess Nono, we're looking forward to hearing your insights. Welcome.
Thank you very much for that beautiful introduction. Gives us hope that there is a tomorrow, and I just am encouraged by the young girl who spoke on behalf of others. And I think that is what all of us here try to do, but we also need to do the work because we can't just speak. So I'm just going to provide you a context of why is it that we are all gathered here today. We've spoken and reference has been made to the fact that we are going to be talking about cervical cancer and the elimination agenda that came into play when our Director General, Dr. Tedros, called the whole global health community to look at this cervical cancer issue and to eliminate it as a public health problem. In a quiet moment, you might want to ask, what prompted this? As has been said earlier, there are many diseases, and we know them because we work on health issues, particularly those affecting women. But this is something that I think we should be enraged about. We really should be very, very angry that in the 21st century, we're still talking about women dying of cervical cancer when we have the tools, we have the technology, and we have the know-how. There is nothing different between somebody in the north who gets infected with HPV and a woman who lives in the South or in any of the countries where we work, poor or rich, it's all the same. But it's a question of inequity, inequitable access to the simple technologies that exist. We've got really to tackle this and tackle this insistently and persistently until we get to the goal. If you turn it on its face, cervical cancer is actually, I don't like even the narrative around cancer because it carries a heaviness around it. And we really should be talking about what are the upstream causes. And true to what the previous speaker alluded to, are the issues that we are discussing in this forum. The fact that women are not heard, the fact that women have no control over their bodies, the fact that people are marginalized, the fact that we've got cultures that we are still upholding that deny us that integrity to our bodies, and we are transferring it to young people. I mean, for us to be called to order by a young girl this afternoon, we should really feel sorry. But we have an opportunity, and we have a great panel that's going to be talking about what is it that we can do. As WHO, we've provided a roadmap. For many, many decades, the world didn't have a roadmap. Now we've got the targets. They are there for every country to try and reach. They are difficult. They are stretch targets. But if we didn't do that, people would not even move. Now we've got the vaccines. But why are they not in Africa? Why are we selling them at high prices to men in the north? And I've got nothing against everybody having access. But I have a problem when we can't get it in countries where the burden is the highest. So the conversation need not be nice when we want to get these vaccines to where we need them. And I'm happy to say that even with the problems that we had with the pandemic, WHO was able to pre-qualify another vaccine, and just 2 days ago, we heard that the Serum Institute in India is going to be churning out its own vaccine. Now, if you have China and India dealing with this and addressing their own needs domestically, it means we'll probably have access for the rest of the continent. More news coming out of our group of strategic advisors about whether we can go with the single dose or not. Very interesting, very exciting, because it means we can save the lives of young girls and we truly can consign this disease into the history books. So there's a lot more that we can say that we're going to hear today. But for me, I think the message for everybody in this room is to start talking about this. I don't understand why we are perpetuating the myths that you are talking about. Why are things around sexuality so taboo? Why is it that we want and are okay with women walking around with so much pain and bleeding? Somebody mentioned that I've studied gynecology, but what I remember about this is the smell of it. It's the pain of it. It's the exclusion. It's the stigma. And I just feel it's not acceptable. And I'm sure all of you feel the same. But the question should be, what are you all going to do about it? I'm happy that the Commonwealth Secretariat, you've put this on the agenda of the Commonwealth. We got to the Commonwealth Health Ministers, and we got an outcome statement. Now we're going to speak to the bosses, the heads of states. And they really need to understand why we have picked this particular cancer for attention. So I'm really honored, and I think it's a great, great opportunity for us to collectively work on this agenda. And I'm just grateful to the Commonwealth for your attention and for embracing this agenda. Thanks, Doctor. And thank you to everybody, especially those who are helping us today as WHO to advance the agenda. Thank you very much.
Thank you so much, Dr. Princess Nono. I think the key aspects that we're picking up from your words of wisdom is really, where is our outrage? And it's not just about, outrage and, holding placards up. It's how do we creatively channel that outrage into measurable deliverables that are going to change the narrative, certainly not just for us, but for the Halimas and all of the women and girls who are coming behind us. I think the other thing you've really talked about is normalizing these conversations, having them in more open spaces. And I think to get the conversation starting, we're going to have a brief video just to sort of set the stage. And while the video is showing, I'm going to ask the panelists to go up to the podium. And let's play it.
When I know that I have this sickness, I just terrified.
So to me, that word cancer was automatically death.
I almost didn't engage with it for a while. I couldn't be a cancer patient at 26.
When the report came out, the doctor called me and she said, it is 100%, it's a cancer stage 2B. That is the first day I saw my mother cried for me and she said, my daughter need to be saved.
You don't want to see anybody dying unnecessarily, but seeing young women dying when they've got young kids, that's something you really have to do something about.
Cervical cancer is the most common cancer that we have in Zambia.
Cervical cancer is one of the only cancers that we've totally figured out. We know what causes it, we know how to screen for it, we know how to treat pre-invasive disease. And so really no woman should be dying of cervical cancer.
O sea, en este momento lo que más me duele es mi hija, ¿sí? Mi hija, porque yo no le quiero dejar.
Tienes cáncer y tenemos que actuar ya porque tenemos muy poco tiempo. Ellos hablaban más o menos de 7 meses de vida.
Y después comienza esa carrera, es una carrera por la vida.
For us to talk about elimination, we're talking about women getting screened, we're talking about HPV vaccination. What Zambia has done basically shows that it can be done by any of the low-income countries.
In my experience, the problem is the same everywhere, whether it's being an uninsured woman in the Rio Grande Valley or being in El Salvador, Africa. It's just really getting access to all the preventive measures that we know work.
So while Australia's on this pathway to being the first country in the world to eliminate cervical cancer, we need to recognise that we have huge inequalities here as well.
The fact that we have an HPV vaccine, an anti-cancer vaccine, means that in a generation we could be in a fundamentally different place than we are right now.
There is a concerted international effort from everyone, whether it's a developed country, developing country. We are all moving towards this goal.
The lessons learned from cervical cancer is how working together actually can make such a huge difference. It's the sound of many voices speaking the same message.
When we have all the weapons at hand, failure should not be an option.
Conquering cancer means a world with women who are empowered to do other things and they're not succumbing to a disease and unable to give their full potential to their families, to this nation.
If there is a chance for me, I will keep on fighting. I will just keep on fighting. Yeah.
We have to take this opportunity, we have to take this moment in history to make this something that we achieve.
The ability to conquer cancer is so powerful. It's amazing.
Do I think we should be talking elimination every place in the world? Yeah, I do. And the question is, how's the world going to step up to meet that need?
Pretty powerful, but pretty disturbing stuff. Every 2 minutes, which is, based on the time that we've been here, is really food for thought. But really, again, the opportunity to think about how are we stepping up. And here today to give us some insights into that is our esteemed panel. And what I'm going to do is I'm going to very briefly go around the room and let them tell us a little bit about how they're stepping up. So first is Professor Marion Saville, who's Executive Director from the Australian Centre for the Prevention of Cervical Cancer since 2000. Welcome, Prof. Marion, and tell us a little about how you're stepping up.
Thanks very much, Miriam. I am a pathologist that has for over 20 years specialised at looking at pap smears, and it became apparent to me about 10 years ago that we've got a better way of doing this, that we have to change the way we prevent cervical cancer. So it's really exciting now that we can change things as we have in Australia. We've changed our screening program to HPV-based screening, and we are working in partnerships with countries in our region, with Papua New Guinea, Vanuatu, and New Zealand, together with Malaysia, and you saw one of our partners on that video. So we really want to throw our support behind the WHO strategy. I have observed that in the time I've been working that it's aligned the conversation so much better about how to do this. Now we just need to get on and do it. And later on I'd like to talk a bit, Miriam, about self-collection, which I think is a key opportunity and enabler for the strategy.
All right. Thanks, Marion. And teaser alert, we're going to talk about self-collection. Next up is Ms. Summer Ng, who is an entrepreneur, speaker, and advocate for women's health and empowerment. Welcome, Summer.
Hi, everyone. I'm Summer. So I'm 30 this year. I'm from Singapore. And I am a cervical cancer survivor. I survived cervical cancer 3 times in a row, actually. And so I... Thank you. So I really think that it's really important to get this message out to everybody, like how important vaccine and prevention for cervical cancer is. So I'm here today to share my story and to hope to inspire everyone as well. Thank you.
Thank you so much, Summer. And next up is Powerhouse, Karen Nakawala from the Teal Sisters, who's going to tell us a little about how she's stepping up.
Hi, thank you very much. This is quite sudden. But my name is Karen, and I am a cervical cancer survivor as well. And after my journey, thank you. After my journey, I realized that there were few voices that were actually talking about cervical cancer from the patient's perspective. And so I decided to take it upon myself and become the advocate that I am today. So I founded an organization called Teal Sisters. Initially, it was just a Facebook initiative, and the evening I set it up, within the next morning, we had over 10,000 subscribers. And within the month, we had over 130 subscribers. And so for me, that just meant that we did indeed, we do need to start having these conversations, no matter how uncomfortable they are. And so that is why we're here today, and I hope we can actually further these conversations from this room.
Thank you so much, Karen, and looking forward to having, as we said, more and more of these conversations in open spaces. And last, but certainly not least, is the impressive Professor Sinait Fisia, who is an Ethiopian endocrinologist at the University of Michigan, who's working reproductive endocrinology and infertility. We're starting late, so I'm going to apologize in advance for Prof, who may have to leave a little early, but we're thrilled to have you on board and looking forward to your insights. Perhaps share a little about how you're stepping up as well.
Sure, thank you so much, and apology in advance. I have sessions booked back to back, and my next session is at the other end of town at 4:30. So unfortunately, I moved to the side so that we don't leave an empty seat. So my name is Sinait Fisia. By training, I'm a physician, a gynecologist. Has been practicing, for over almost 20 years, and a human rights lawyer as well. This is an area, I was born and raised in Ethiopia and went to the US for education. So looking at the disparities, the inequity between what happens to a woman who gets diagnosed with cervical cancer, if she ever is lucky to get diagnosed, versus women in the West was such a stark difference for me. So this was, so when I was in academics, I was trying to introduce cervical cancer screening at scale, not just at academic institutions, but at the Ministry of Health in Ethiopia and doing other things. But how I am stepping up right now is working with Dr. Nono Simelela and Dr. Tedros, chairing the Director General's Advisory Council on the Elimination of Cervical Cancer, where I have a little reservation around moonshot. Moonshot sounds like something you may not achieve, right? This is something we are going to achieve. As the Director General you saw in the video, it's unconscionable. We have all the tools. This is one cancer we know how to diagnose, how to treat, how to prevent. So we have set out a very bold agenda where we've said we want the 90, 70, 90. If you don't know about it, we want by 2030, we want 90% of girls under 15 to get HPV vaccination, 70% of women to get their first screening by 35, and then 10 years later by 45, and 90% of those that have pre-invasive cancer to be treated, and 90% of those that are actually diagnosed with cancer to get aggressive, treatment and management. So that is how we're stepping up, and our call is that all of you in the room, plus all your networks, will step up with us to actually eliminate a cancer that just does not need to be a cancer.
Thank you so much, Prof. Sanait. And I think you raised the point around cancer moonshot. And I think right now there's I would say, grassroots initiative around cancer groundshot, which is really saying, how can we in low and middle income countries actually have the basics? We're not asking for the moon, we're asking for the ground. Let's get the basic drugs, the basic treatments, the basic screening tests. And so, Prof. Marion, we do know that a key is screening and early detection, but we know there are a considerable number of barriers to this, but what are the opportunities around this?
Well, I think the first opportunity is the accuracy of the test, and the fact that you've just heard that 2 tests in a lifetime can make a huge difference to incidence and mortality and can save millions of lives around the world over the century. 2 tests in a lifetime, that's not like the screening programs we're used to when you have to come back every 3 years. That's something achievable to roll out. And what we're hearing from countries around the world is that the access to the tests at an affordable price can be a problem. I think that's improving. I know the WHO is working on market shaping and pre-qualifying more tests. But these tests, when I speak to people in countries saying they're too expensive, you have to remind the government that it's 2 tests in a lifetime. It's not something that you need to do every 2 or 3 years. And it's incredibly effective. It's so exciting. I'm someone who made their whole career out of the old technology. I'm excited what we can do with the new technology and make a difference around the world, and addressing the inequity that exists not only globally between countries, but even in a country like Australia, where we have profound inequity in who gets cervical cancer, and these are marginalised populations. So we've got work to do, but I think the other barrier is the speculum exam. And it's problematic for 2 reasons, and particularly in our marginalised communities in Australia and countries we've worked with in the Western Pacific. There are cultural barriers to the speculum exam that are well overcome with self-collection. So self-collection is using a swab that you would have had having a COVID test. That swab only needs to go into the vagina. It doesn't need a high level of skill, and it can be delivered by health workers who are not necessarily nurses and doctors. And that is a fantastic opportunity, in my opinion, for 2 reasons. One, because of the profound acceptability we find in all of our projects in a range of cultural settings, almost a sense of relief when people have screened because they've been putting it off, because they won't have the speculum exam or their husbands won't let them, or for whatever those reasons are. But secondly, at the scale that you've heard about, 70% of women between 30 and 49 we've got to get to in the next, 8 years. That's billions of women. So the health workforce required to put a speculum into all of those women, it would be very challenging. But what we can do with self-collection is we can use health workers to educate, show women how to collect the sample, and save our trained nurses and doctors to examine women in whom we detect HPV who need that follow-up care. So I'm just so excited at this opportunity. And I think we just need the advocacy to have our governments around the Commonwealth provide the financial and human resources to roll out this screening.
Yeah. And you raise a very good point, Prof. Marion, around how all this does come down to, investments. And you also raised an interesting point, Prof. Senait, around how this is a social justice issue. So I guess the question is, how do we, we've come up with this lovely framework, we've defined the goals, we have some forms of commitment, but usually the drawback is, we don't have enough cash to maybe transition from VIA to HPV testing. How do we hold governments accountable, and how do we sort of give them that extra nudge in order for them to make a difference?
Do you want any of
I was saying from a policy perspective.
Perspective, yes.
Most of the time we only have state amount of funds, and of course we're all looking at value-based care because you want to give quality care at a cost-effective rate. So what is the narrative? How do we then sort of implement on the ground?
Absolutely. We see a lot of strategies, right? I think one of the things that we've really become good at the global level is writing amazing strategies. We convene, we set goals, they're incredible. We usually don't achieve them, then we push the goalpost, right? Like we did MDGs. We made progress, we didn't get there. So I 100% agree with you. The strategies don't mean anything if they don't get implemented. But we also know that the excuse of resource limitation is not, it's just an excuse. You see countries like Rwanda with meagering resource that actually put value around the girl child, that have vaccinated over 90% of their girls with HPV vaccine. So shout out to Rwanda, yes. So for me, political will matters, right? So yes, we do have limited resources and we have to prioritize, but prioritizing women and girls, you talked about the stigma, right? So for me, this is one of the many burdens women carry around the world, particularly in low and middle income countries, particularly in sub-Saharan Africa. The fact that we're so comfortable with maternal death, with maternal mortality, that we stigmatize anything that has anything to do with sexual intercourse, whether it's cervical cancer or unsafe abortion or access to contraception, frankly hiding behind all sorts of cultural, social norms. For me, it is about the value we place on women. So when you have leadership that values women, they would come up with the money. They would prioritize treatment, screening, prevention, and that goes to all spectrum of services women and girls need across their lifespan. So for me, I think, of course, advocacy. You need advocacy at all levels. Prof. Mariam talked about Commonwealth, right? How do we rarely get a cancer that we can prevent and cure. So this is such a lost opportunity. 342,000 deaths annually. Of this, 90% is in low and middle income countries. We now have tools. Prof talked about self-screening. We have vaccines, we have treatments, we have the tools. So how do we mobilize the global community to put resources? But how do we also fix a broken system? What we saw with the COVID-19 pandemic is that we no longer could rely on the existing global health supply chain system. We can't rely on experts from multilaterals flying in. So what the COVID vaccine, what the pandemic has done due to the inaccessibility of vaccine is shone light in the deep inequities that the system that we've built, both globally and nationally, is really weak at best, but really a failure in most systems. So how do we now dovetail on this whole global conversation, as Prof was talking about for COVID-19, and build on the technology innovation? How do we build on getting services to women instead of expecting them to come to facilities? How do we train women for self-care, for vaccine administration, for prevention, STI detection? So there is a lot of shift we need to do. We need to diversify the workforce. We need to invest, start producing diagnostics and therapeutics, diversify our workforce, increase our investments, and more importantly, encourage, civil society. For me, I was at the People's Forum this morning. It's incredibly powerful, and I think this is where, again, the Commonwealth can play an incredible role in building the capacity of civil society locally, not the ones that we fly in without having a local context, but the ones that have deep understanding of the problems as well as the solutions. So I think if we do even half of this, we're going to be able to make enormous progress. And also measurement, right? How do we, someone talked about this morning, naming and shaming. As much as we don't want to do that, countries like competition. We do it along so many other things, but when it comes to maternal mortality, we do it for pandemics. We rank countries. Of course, it didn't hold water. The countries that were ranked very highly before the pandemic didn't fare well. But the truth is, we do it for so many things. Why not rank countries? Are they delivering on the commitment? Because WHO is a member state organization. So when you have all of them go and sign a pact saying we're going to implement this strategy, how are we going to hold them accountable? So whatever is not, counted does not count. So I think putting measurement with it, holding countries accountable, naming and shaming, but simultaneously increasing domestic resources, global resources, and focusing not just on cervical cancer, but all things that hold women back in society.
Thank you so much, Prof. And I think really, as you said, looking at the woman holistically and not just focusing on one aspect. I think that's the challenge that we've had so far, just operating in silos. But then one of the points that you raised was a real need for advocacy and the need to have these conversations in different spaces. And I think perhaps, Ms. Summer, you might reflect on, sometimes people don't think the youth most people sometimes think that this might not affect them, but what would be the strategy for, engaging at an early age? We're talking about getting your vaccines. What would be the message to encourage adolescents and shared knowledge around intergenerational knowledge sharing?
Well, first, I was diagnosed when I was at the age of 24. So people think that cervical cancer only happens to women above 35 years old, but I was only 24 then. And at the time, I had a dream of being a mother, and the doctor was actually telling me that I have to remove my womb that is the only option that I was given for my treatment. It really got me quite, I was very affected by it, definitely. So I was like thinking in my mind, what happened if my doctor is a male, so if I asked him to remove his penis, what would it be? That, in that sense. And it's like losing my identity as a woman as well. The womb, and I want to be a mother, and if I have to remove my womb, I will not be able to fulfill that dream. So, and I did not give up actually in the end. So I went to research online and to find other alternatives for treatments and to seek other opinions from other doctors as well. And I found out an alternative. So the doctor said that, oh, okay, we can do that. And when I heard that, I was actually quite angry. It's like, why do you actually give me that only option to remove my womb and not other options that I can have to save my womb in that sense? So I was thinking maybe that he didn't consider my age or the stage of my life, that I'm still young. And when I was at the cancer center, everybody there was like above the age of 35. I was the only, I would say, youth in that cancer center. So I think it's very common for doctors to just remove the womb for other women because they have given birth, they are married and everything. It doesn't really matter to them anymore in that sense. So he thought that it might be the only option for me, and definitely I don't agree with that. So I had to thank myself for that, actually, to save my womb and not give in to that. So yeah, but not everyone, I feel like not everyone actually can have that strength to actually have that clarity to seek for other alternatives. We trust our doctors because we do not have the knowledge of what our condition is. So we put our trust in our doctors, and I felt betrayed. Like, if I would not go out there to find out more options, and I would not come to this, I would not have even saved my womb. So I hope that, it's not that I don't trust doctors now. I would think twice, I would do more research. But I also found out that on the internet, there's limited information as well. And also there's a lot of misconceptions whereby cervical cancer is it's due to sexual activity, but it's not a disease, it's actually a virus. But then, we will be judged by how people look at us, like, because we are active in sexual activity, and then they think that we deserve that in that sense. But actually, it's not a woman's problem. It's actually it's responsible for men as well. Men should actually take the vaccine at the same time. But I will not put the blame on either a man or a woman, because it's part of nature, right? The virus is inside us. We just do not know when it will become cancer in that sense. So the vaccine actually helps to prevent the virus to be a cancer. It's not within our control to know when the virus will become cancer, but it's within our control to actually take the vaccine and prevent the cancer. So I hope that the youth can actually take the first step to take the vaccine and the screening to prevent and eliminate cervical cancer altogether. Yeah.
Thank you so much, Summer, for those very, very powerful comments. And I think the key thing you've said is really taking, I think what most of us in the room are sensing is you're taking agency, you were taking control of your health, despite the doctor saying, listen, you need to have this drastic operation. You sort of did your background and came up with an alternative conversation. And I think as a clinician, I would hope that the model of healthcare where we sort of come down from the mountain and give you 2 tablets and tell you to take them is long gone. It's overdue. And so really it's about shared decision making. But shared decision making cannot occur in a vacuum. Patient needs to be educated and informed to know the right questions to ask. And so, Ms. Nakawala, I think the question is, how do we then get our patients empowered or have agency to ask questions? And how do we enhance the shared decision making for patients with?
I always say that the best doctor is the person who's lived the journey. Mm-hmm. And we have an opportunity right now, I mean, in the young lady Summer, in myself, to be able to take the mantle and be the ones to help our patients. Now, how do we do that? The first thing is, as a survivor or as a patient, I need to be accepted the way I am. Like she said, it's not in my control. We need families, especially immediate families, before you can actually take it out to the community and to the other patients. We need to make sure that everybody around the person, the patient, understands what it is that they're going through. If I am going to be able to own my space, no matter how painful or how hard or how difficult it is, I need to have the support of those people around me. And how do we do that? I think it should come in the messaging that we send out to the people. For the longest time, the messaging has just been to the person who's been diagnosed with the cancer. Mm-hmm. It's never included the people around that person. Mm-hmm. And I always say that when you're diagnosed with cancer, trust me, everybody else around you is diagnosed with cancer. They may not go through the pain you're going through, but they will experience it through your pain. But if they are educated from the onset, from the diagnosis, if you've got your husband, your children, and They understand what it is, what the treatment will do to you, what the side effects are going to be. They'll walk that journey with you. And so when we go through the treatment like that, at the end of it all, because I was comforted and I was supported, it's very easy for me now to be able to speak to the next patient and be able to put them in a place where they're able to ask the right questions, because I've walked that road. Okay, so I need to have the information right from the onset. But if there's somebody that I can look up to, it is much easier for me to be able to actually ask the right questions. I've got people that will come and ask, okay, so at this stage, I've got my first chemo, I got my radiation, what happens? And I ask, haven't you asked your doctor? And they're like, no, I feel it's easier for me to talk with you because you've walked that journey. And so I think it's very important when we curate messages that they should include husbands, they should include children, they should include extended family, they should include community. Because then that way, I think there'll be less stigma, because patients sometimes will be scared to ask the doctor questions because of fear of stigma. And sometimes they'll get side effects that go untreated because they don't want somebody to keep on intruding and looking down on them, because you think whenever a person sees me, they look at this person who's promiscuous, or she's very sexually active, like Summer said, and they don't realize that it can happen to anybody. It can happen to you as long as you're sexually active. And so I think it should start with the way we do the messaging, and we need to use survivors as much as possible, because it's relatable. Like I said, it's relatable to listen to somebody who's worked the journey than somebody it's just your job, doc, you know what I mean? And you've studied that. But for somebody who's worked the journey, it's much easier. So we need to find a way of bringing the survivors and the patients together so that they can start talking. That way it will be easier for them to go to a doctor and ask whatever questions they may have. But we need to enable the environment for survivors to thrive. We need to accept, we don't need to stigmatize. Dr. Nono spoke about stigmatizing. Once you stigmatize, a lot of women are going to die in silence. I know women who've been diagnosed and they don't want to go for treatment because they think the community is going to start, talking about them. I know women who've lost their marriages after a diagnosis, but that's because of lack of information. I know women who don't want to go for screening because they think when they see them going into a screening room, automatically people will start talking. So I think we need an environment that is enabled for us to thrive in order for us to help the other patients that are coming along.
Yeah. Very, very powerful comments, Karen. I think really the two things you've raised around the need to reduce stigma and really having these conversations, I think, in more spaces, but also from the healthcare provider, I mean, really having the respectful care, really contextualizing messages in a way that's culturally sensitive and appropriate and makes sense to the patient, but also mobilizing the immediate community. I think there's an African expression that when you're well, you belong to yourself. When you're sick, you belong to the community. So really, it's those communities and spheres of influence around you that really need to be enlightened. I think in terms of the pandemic, and we sort of talked about health systems and how we've taken a hit, but as we said, we're looking for opportunities and silver. Prof. Marion, what are the silver linings or opportunities that we can leverage on as a result of the pandemic as far as cervical cancer elimination is concerned?
I'm happy to talk to that, but before we go off stigma, I just want to let this room know that 90% of us will have an HPV infection sometime in our life, and it is a normal part of being an adult person. Some people with HPV infections get them because they've been sexually assaulted. So let's destigmatise and let's get that information out. Also, it's a chronic infection. So you might have acquired the HPV when you're a young person and you might not get cancer for 10 or 20 years later. So really important to understand that destigmatising information. This is not like some of our other STIs where they're acquired a couple of weeks before detection, and it will happen to almost all of us, and mostly we don't know it because our body clears the infection. So just really wanted to get that information out to this group. I think the pandemic has parallels. Cervical cancer, one of my colleagues has said, is a slow-moving pandemic. It's caused by a virus, and it can be controlled vaccines and PCR tests that we all know about. So the community broadly has a much greater understanding of PCR tests, I think, globally since the pandemic. And we can build on that understanding. But more importantly, there's been the establishment of capacity to do PCR tests in a lot of countries around the world that didn't previously have it, or expanded capacity. And so I think we have an opportunity to be using those investments now within the context of HPV screening. I think that's a really important opportunity.
Thanks so much, Prof. Marion. And I think, as you said, leveraging on existing technologies and trying to see how to strengthen those. I think, Prof. Singh, just before you leave, perhaps you could comment on sometimes advocates would like to motivate for themselves, but there's a lot of the stigma goes beyond. I mean, if you look at stigma, there's levels of stigma. Right, there's a community, but even when it comes to their interactions, we're having patients who are, losing their jobs because people are, think they might be contagious, or they're taking too many days off. So, what are the legal sort of frameworks or structures that we can put in policy to ensure that the rights of our patients are upheld?
Yeah, no, I think that's a very good question, and that goes far beyond cervical cancer. As you know, workplace discrimination is a very common thing, and our moderator has raised not only workplace discrimination. Of course, the legal framework is in the context of that. You see discrimination during pregnancy. Women get discriminated for breastfeeding at work. A lot of it, again, I'm going to keep on, I'm going to sound like a broken record, but I think inherently when it comes to women, it's about value. It's about not giving women agency. It is about how much we value. I mean, in most sub-Saharan and Southeast Asian cultures, women are disposable, right? Like when you are, if your husband dies, you get burned with him. You're dying childbirth, your husband gets. A lot of this are a rooper social normed when women get ill. But absolutely, we do need policies, we do need social protection, not just for cervical cancer, but any kind of illness, that women should not be, it's enough to lose, your sense of self when you go through a cancer diagnosis or any other illness. So we do need policy protection. We do need the problem for that. I'm going to speak, I've been here after having lived in the US for 35 years. I've spent the last 2 years in Rwanda. The reality in this continent is that most women are in the informal sector. They don't have insurance, they don't have protection, so it's really the quote you used, your family becomes your protection, your community becomes your protection. So how do we sensitize? I mean, I think till sisters, right? Like, how do we get information out to the community? How do we destigmatize? This is just a virus we all carry, just manually delink it from this hypersexual feature it gets given. I mean, both of our survivors' patients talked about the label it comes, and I think a lot of it starts with education. And education, as you rightly said, starts with your immediate family, right, with your surrounding, with your core. And it's also human nature. We tend to be so judgmental when the issue is far removed. The moment a family member is affected, I see this with access to safe abortion. There is a lot of stigma. I mean, in the United States right now, we are about to find out that, abortion rights are being restricted. But when a person whose family member needs those services, whether it is because they have malformation, fetal malformation, or severe morbidity, or some other stuff, people start wavering. Those restrictions, those concerns start going away. So the family, the immediate family, is a powerful tool to break this taboo, to break this stigma. I will even push it further. Our healthcare providers are not well equipped. In fact, they perpetuate stigma when it comes to women and girls, partly because they are not well trained, well equipped. They have so much burden to take care of, right? So when a patient walks through the doors, just like you're a number, you are statistics, it's not that loss and deep, profound loss that the patient's experiencing. So how do we start educating the healthcare provider? How do we start diversifying? When we move to self-care, self-testing, when we start, we've now seen with COVID, community health workers are doing screening. So the same devolvement that Prof. Mariam talked about, we now have an incredibly effective system. But the lesson from the past has been, we respond vertically. We respond for COVID, we respond for HIV, we respond for TB, we build vertical health systems, the resources will come with that, and then whenever that problem is fixed, the systems collapse. So I think, going back to your earlier question, what's the opportunity is, how do we take and strengthen health system, primary healthcare system, so that we are able to detect, prevent, and respond to emergencies, but also take care of communities holistically, and really start focusing on prevention than curative services. Whenever you travel in sub-Saharan Africa, the biggest focus is on building the biggest tertiary care center, training the most advanced, and those are important too, right? It's about inclusion. We don't want anyone to be discriminated, but when you have limited resources, you have to prioritize. And you have to say, it's the 80-20 rule. Where do I put most of my resources to reach the largest number of people at scale? And I think that's where we need to have a very strong primary healthcare system with a diverse workforce that gets the education, the sensitization, the advocacy very early on, so that instead of perpetuating stigma, healthcare providers then become additional advocates to the patient. So with that, if it's okay with you, I'm going to say goodbye and thank you, and ask to be excused to go to my next panel. Apologies again.
Thank you so much, Prof. Sainet. Thank you so much, Prof. Sainet, and those were incredible insights. And I think really around your point around strengthening the primary healthcare system, because the primary healthcare providers are the gatekeepers to access. And so really tightening that will go a long way, perhaps, towards around stigma. We're going to briefly open up to the floor to address to the panel. Yeah. Oh, sorry. Okay, there's two. I'm trying to see the mics. Oh, and there's one here. There's a lady here, and then the lady at the back, and then there was a lady on that side. So maybe we can take three.
Solange Habineza. I'm from Phoenix, Arizona. I'm working in healthcare. There is something I need to talk. If someone has like 20 years old or 29, it's necessary every year to do like pap smear test to screen like cervical cancer. And then if someone has like 4-year-old and up, it's necessary for mammogram, because it is necessary to taking care of ourselves. Thank you so much.
Thank you, Solange. I think that was a comment around the need for screening. Next.
Hi, I'm Natalie, and I think I wanted to just bring back the point on information. So here we're talking about cervical cancer because some of us are aware. I would say even a lot of us are unaware and are learning during this session. I'm an educator. I run a university, and I considered myself highly educated until I had a cervical cancer scare. And then I did a lot of reading, and then I was more aware. And all of a sudden, then I said, okay, all the girls that come through our doors need to be aware of not just cervical cancer and HPV, but all the other. So if I had not had that personal experience where I was, I fell off my chair when they said, hey, we're going to look into this, it might be cancer, I think I work in public engagement, and I think we have to go back. I think Prof. Sainet talked about how do we do it women to women, right? How do we look at women in the informal sector? But I think there needs to be, beyond saying we're going to vaccinate our young girls as a policy, as a government policy, what are we doing in terms of the information young women are consuming to be able to give them the type of information in ways that they're consuming to talk about this before you even get stigma, you need to be aware that you could be at risk, right? And I think that for me, I've lived in Canada, I've lived in 17 years, and the only time I heard about it was when I was at risk, right? So I think we need to really go back and say, when do we start? Like all ecosystems, before you talk about self-testing, people need to be aware of this and that it can be eliminated, etc. So I think public engagement at every level and starting quite young in ways that young people consume information, as opposed to nice policies that come from government, and then they tell you go get tested, and you think that you don't want to get tested because then it comes with stigma.
Thanks for those excellent observations. I think we'll take one more comment, and then we'll get the panel to weigh in. I think the lady, yeah, go ahead.
Thank you. This has really been very interesting. Karen, I really applaud what you're doing in Zambia. So 3 things. One was what Natalie just mentioned about information, people actually having the information. And I belong to the Medical Women's International Association, and that organization has existed for over 100 years. But it looks like we're probably not doing enough, because our major campaign is the Worthy campaign, WORTHI, which is women's rights to health information. So maybe I'm going to take this back to MWIA, that we really need to push more of this information, because our focus too is on women and children. So we're definitely missing the mark there on getting that information out. It's really key that people need to know, and maybe from a really young age. My second point is on integrating care. Madam Moderator, you mentioned, you asked the question around financing. It's not just about having the policy, but how do we ensure that governments actually commit and implement those policies? And I think Professor Senait actually mentioned, sort of touched on it, being able to say we're caring holistically. And the intersection between HIV and cervical cancer actually gives us an opportunity for that integrated care. And we know a lot, there's been a lot of talk about HIV. We know that the women who have HIV are at higher risk of more serious HPV infection and get sicker with cervical cancer. So that could be one way. A lot of nations already have programs for HIV screening and testing and treating. Can we piggyback cervical cancer screening and treatment on that, while also adding on all the other, because in any one human being, women are also having breast cancer, colon cancer. We really need to think about having a holistic, integrated formula or framework for dealing with all of this. Thank you.
All right. Thank you for those excellent comments. Perhaps I'll get the panel to react. I think there's critical points around how do we ensure the messaging is correct, how do we educate and ensure that the messaging that's coming out is correct.
So I'd just like to say and to reinforce, this virus will infect probably most of us sometime in our lives, and we need to destigmatize that, and we need to get that message out there. You can carry it for years without knowing you've got it. So it is completely different, but it has a complex biology. It's hard to understand, and it's challenging to educate because of the ways in which it's a non-communicable disease. It's caused by a virus. It's a very interesting thing, but it is very challenging. But I really want to pick up on the intersection with the HIV/AIDS community. I think we are starting to look in some of our projects in Papua New Guinea about where we deliver cervical screening in a scale-up implementation project. Broadly, that's going to be in the context of Well Women's Clinics delivering sexual and reproductive health services, but we will separately integrate into HIV care services. And I just want to finish by saying, drawing on what we heard from Nono, we have to be agitated about this and call for the rights of girls and women to have access to these services. And the HIV/AIDS key have shown us a way to do that. They have been quite effective, and I think that dialogue with the health providers for HIV/AIDS, with the community, could be very productive about how do we go about the advocacy, the education, and the integration into other health services.
Can I add on to how? So, like, how to actually get the message out, especially to the youth. So I am actually the active ambassador for A4HPV. So it's from the Commonwealth Youth Task Force on HPV and cervical cancer elimination. So so I'm from Singapore. So what we are doing right now in Singapore is that we have this campaign called the Iron Campaign, which we hope to actually get people to pledge and to eliminate cervical cancer together, and we hope to bring it across the whole Commonwealth as well. So this is actually a youth-led initiative. So we also hope to get everyone's support to bring this initiative to the Commonwealth. Yeah. So.
Okay. She touched on the young girls especially. Back home in Zambia, we do have a curriculum now for, I think it's in primary school. They have a curriculum on sexual reproductive health. And so they're trying to embed cervical cancer into the subjects. And so they tend to, they're now trying to start them early, giving them the information. But the question is whether the teachers are actually well equipped to give out that information, but otherwise it is in the curriculum. And when it comes to community engagement, when you want to send out information, I think it's up to each and every one of us in this room. I'd like to challenge the female leaders that are here. This is what you should be doing. I think every day that you wake up, have a woman agenda to do something to save the girl child especially. I think they deserve to live in a cervical cancer-free future. So it's up to all of us. We've got first ladies that are here. This is something that you can do, leave a legacy for that young girl. I'm a civil society. I don't have any funding. I have to fundraise to actually disseminate information to the rural women because they just don't have internet. And I can tell you that 90% of people that support are men. The women, you literally have to, it's like drawing blood from a stone. But I think it's up to each and every one of us. I don't think you want to go through what the both of us went through. You don't want your child or your niece to go through what we went through. So it's up to each and every one of us. I was hoping that this room would be full for this session, especially that we have the men here, because we cannot fight this thing alone as women. We need the men to work with us. So it's each and every one of us to go out there and give out the information. We've had this discussion now. Don't let it end here. Go out and disseminate. We have the internet. For the youth, we can use digital space because they're always on their phones. And we can pass on that information. So it's up to each and every one of us to educate the next person. I think that's what I'd have to say.
Thank you, Karen, for those powerful comments. Maybe we can take the last two and then we can close. I think there's a lady in pink and then there's... I can't see. Sorry? Oh, okay. And then...
Thank you very much. I am Fatou Kinte, the Minister of Gender, Children and Social Welfare from the Gambia. I think when it comes to cervical cancer, we need to be doing the education on a day-to-day basis. Yes, I do agree. October 2nd, we are busy doing the campaign on radio and television, and then we refer women to a few clinics for screening. But I think between October and October, it's too far. In our health facilities, the health staff do have health education, doing antenatal services, and also doing infant welfare clinics. I think just as they talk about family planning and other issues, they should be talking about cervical cancer and other cancers that affect women. I think we should organize or have well women clinics in our facilities across the country, be it urban or rural. So when health staff do talk about cervical cancer and other cancers in health education, they also refer women to the well-women clinics, where women can go for more counseling, more information and services, and then they can also do the screening. Limiting it to only one facility is not enough. And about the stigma, I come from the Gambia. We don't stigmatize cancer, unlike in other countries. Because when the campaign is on in October, women walk into the facilities freely for the screening. And I strongly feel that we should go beyond that. We should use the integrated approach to health programming and make sure that we talk about cervical cancer and other cancers affecting women, just like we talk about other health issues, like malaria, STIs, and the need for family planning. We must all work together. As Professor said, I think those who have started doing it, we should start from here. We should all work together because we are in this together. And it's only when we work together that we can create awareness and prevent the different types of cancers. And where there can be treatment, make sure that treatment is made available. But it requires the work of everybody, government, civil society, private sector, individuals, be it in school or out of school. Talking about in school, we have the program on comprehensive health education. It's funding from UNFPA. It's not, we are not talking about the cancers, but listening to you speak, I think this has now reminded me that we should include cancers in that program as well. We are talking about other issues, growing up and its responsibilities, reproductive health issues, gender-based violence, FGM, child marriage, but I think it's also critical to talk about the different types of cancers because when we catch them young, when they're in school, you do the education, they know what to do, what to look for. I think they'll be in a more responsible position when they grow up to address the issues accordingly. Thank you so much.
Thank you for those insights, and perhaps we all need to go to the Gambia to find out, get some shared learning lessons. I've seen Dr. Princess Nono has raised, wants to make a quick comment, and then our youth ambassadors at the back. And then we have to close, unfortunately. Yes, go ahead. You can sit wherever's more comfortable.
No, I wanted to offer a challenge, like Karen said. I'm a little bit disappointed that this afternoon nobody spoke about closer. Okay. No, I was just saying that that's where everything comes from, you know?
Exactly.
Like the STIs we're talking about today, the antenatal care that people are talking about today, I think we have so frightened young people from talking about sex, you know? Adults pretend that the sex is not pleasurable, that they're not having sex, that young people mustn't have sex, you know? I think we should have a conference about the pleasure of sex. So we demystify it. No, it's honestly true. We're putting up so many education things, but nobody wants to stand up and say, here is a natural thing. You are the first lady I've heard speak about an admission that you had a feeling that comes with being human. We're running away from that. And when we then get HIV, unwanted pregnancy, you then get cervical cancer, it becomes a big deal. I challenge all the women in this room, talk to your young girls, your daughters, about what this is about. It's not a mystery, you know. We've worked with HIV for decades. Prof, you know, Karen, everybody knows about this. But we are so scared of just talking about it, not as something that's going to cause a disease, but as something that we will continuously do because we're human beings. And there is pleasure, you know. If we deal with that, I honestly believe we will have less disease. You know, this is an unfinished agenda, from HIV to cervical cancer, back again. And we can stop it. We really can stop it. Every single one of us in this room can make a difference. Talk to someone about what happens when you are having sex, just like our colleague said.
Thank you so much.
question, just to add on to what Dr. Nono has said. I think in Africa, we want to pretend that these things are not happening. We want to pretend that our children do not know about sex and that they're even having sex. I think we should normalize discussing sex with our children. It's not a taboo anymore. I think you'd rather discuss with them and protect them, you know, from all the vices, from unwanted pregnancies, HIV, cervical cancer even. So I think we should normalize discussing sex with our children in our homes before they can even go out to school. We shouldn't leave it to teachers to teach our children. We need to do it ourselves.
And I think that's an excellent comment, Karen. Unless we teach our children, the world will teach them, and that's not necessarily what we want to share. So I'll take one final comment. Sorry, I think we're running extremely late. I'm seeing Natalie giving me a bit of a side eye. Go ahead.
Great. Well, I just want to start off by thanking the panel, and particularly Summer, for sharing her own story and her own experience. It's been really exciting, actually, today to hear these kind of focuses on intergenerational education, but also those conversations that can happen between your family, between your peers, and in your community. I'm with the Commonwealth Youth Health Network, and I also wanted to really come in on this point around awareness. So yesterday at the Commonwealth Youth Forum, we launched the new Commonwealth Youth Task Force on HPV and cervical cancer elimination. And this is the culmination. This is the culmination of work that young people have been doing already in their communities about educating their peers, demystifying conversations, talking about sex. Because actually, you know, those conversations between young people that start to talk about what is this really about? Is this something that we can talk about? Is really important. And one of the things that we are really aiming to do is demystify HPV and cervical cancer, empower young people to fill that gap that we see between what health agencies and governments tell you about HPV in technical scientific language, what the private sector put out there on the internet, and actually where young people are really accessing information. So we want to empower young people, and Summer is one of our amazing advocates that actually go out there and spread the word. We also want to put young people in positions where they are advocating and holding governments accountable, because we need greater action and we need to accelerate action across the Commonwealth right now. And we also want to advocate for a gender-neutral approach to HPV vaccination, because actually, as we talked about, this isn't just a conversation about women, and this gendered approach is really harmful. So actually engaging young people in conversations around access to vaccination is a really great entry point to normalize this and make this everyone's agenda.
Yeah.
One of the things I really want to plug while I'm here is we have launched the I Am campaign, which really focuses on stepping up young people and our allies, stepping up and pledging to take greater action on HPV and cervical cancer elimination. So we'll be at the back at the end of today with some bags, some pledge cards, and we really hope that you'll engage with us, share your pledges, share your ambitions and what you're going to do when you come away from this meeting to make sure that cervical cancer can be eliminated, and it can be eliminated soon. Thank you.
All right, thank you so much. And I think the youth are way ahead of us in having this conversation around sex. Perhaps the next conversation would be trying to have enhanced intergenerational discussions where we get the adults to finally acknowledge that we didn't come from a stalk, right? So well done. And we really have to close. But as I said, this is an ongoing conversation. I think we will get our final comments from our esteemed panelists, and then we are going to do something a little different. We are going to stand and have an I Am campaign, which I'm hoping the youth ambassadors at the back will help us to organize. We're just going to stand briefly at the end of the session and say, I am. But I will just ask our panelists to give any closing remarks, any parting.
I'll make mine really brief. If there was a cancer that only affected men and could be prevented with one vaccine and 2 tests, I think we'd have it sorted by now. This is a gender issue, and we need our rights to these services around the world.
So I'll make it brief too. So mine will be age. So youth, cancer is relevant to the youth as well. It's not only to any other people who is older, but it's also for the youth. So I want us, the youth, to take actions, take responsibility for yourself, and take control of your life, and make the right decisions and take the right actions as well. Yeah.
It's very difficult for me to be brief when I'm talking about cervical cancer, but I'll try. So I think in closing, I'd like to once again challenge the leaders that we have here from different countries. Yesterday I had a chance to chat to Honorable Kaliati from Malawi, and when I told her that I'm a cervical cancer survivor, she immediately gave me her number. Because I told her to say, look, we need to work together as countries. We need to collaborate and learn from each other. Best practices, what has worked in Botswana, what is working in Zambia, what has worked in Rwanda. So as I leave here, I'd like to get contacts of all the ministers that are here. I see the minister from Zimbabwe. We have our beautiful minister here from Rwanda and Gambia. It's time we put our efforts together. Because working in silo doesn't work, but they say in numbers there is strength. So we need to work together. And then also, let's normalize talking to our children and our families. And also, can we have the HPV vaccine accessible on demand? And this is in all countries. In my country, we only vaccinate girls between 14 and 15. But right now, because now a single dose is able to protect the girls, can we have it on demand so that we have all the young girls between 9 and 14 quite early vaccinated? Because we know our kids are starting to have sex at a very early age now. We know of teenage pregnancies from 9-year-olds, 10-year-olds. So let's catch them when they're early. And to all of you, if you've never screened, please go for screening, because early detection does save lives. And I can tell you, chemotherapy and radiation are not biscuits. It's not child's play.
No,
so get screened and save your life. Thank you.
All right. Thank you once again for the excellent session. I will be very brief. I think the things we have touched on are really around self-care, really getting our girls and women to take agency, and that comes with multisectoral approaches. We do need to mobilize civil society, but really ensure that the messages that we're sending are in a socially culturally appropriate manner. We do need to diversify the workforce and really strengthen the gatekeepers who are the primary healthcare providers. And I think we've talked about really looking at ways of increasing investment. There is no panacea, there is no substitute for dysfunctional health systems. And so it is important to increase investment across the entire care continuum, really emphasizing the prevention, treatments, and ultimately survivorship, so that our women and our girls can have a better experience of this. So with those remarks, I think there's a couple of bags going around the room. I think the plan is to maybe have our panelists and everyone sort of stand and declare their pledge. Eileen, are there some bags for the panelists?